Speaker will be Graziella Scudu. She works as the Guatemala Program Manager for the Clinton Health Access Initiative, and she directly supports the National Malaria Control Program within the Guatemalan Ministry of Health. She'll be speaking today about surveillance strategies to target workers on sugarcane plantations in Guatemala.
Thank you for introducing me, and thank you for having me here. Today, I want to show a strategy that the Ministry of Health of Guatemala and the sugarcane corporate sector are implementing in Guatemala in order to increase the coverage of case management and surveillance for at-risk population. Guatemala is committed to eliminate malaria by 2020, and in 2017 in Guatemala were reported 4,083 cases, and the majority of them, nearly all, were caused by vivax. As you can see here in the map, the majority of the cases are reported in the south of Guatemala in the department of Escuintla. The department of Escuintla is characterized by the presence of large sugarcane plantations, which cover approximately between 60–70% of the territory of the region, and they are organized under the Sugarcane Association, ASASGUA. Every year, the plantation attracts formally 20,000 of workers. 60% of them are coming from other departments and from surrounding highlands to cut the sugarcane during the harvest season. The harvest season corresponds also to the peak of the malaria season, as you can see here in the graph, that take place from November through May. And the sugarcane workers, when they come to the plantation, they live in the plantation. And in this map, you can see the overlap between the predicted incidence and the location of the plantation. And before strengthening case management and surveillance, for example, this dormitory has not reported cases, while one nearby locality had in the previous harvest season an average of 37 cases per 1,000. Also, this other dormitory reported an incidence of 0.76 cases per 1,000, while they are in a territory with the predicted incidence of more than 35 cases. This is suggesting that there may be cases not reported in this area. Also, this is related to another aspect, which is the particular vulnerability of these workers. They have a high occupational exposure. They go to work very early in the morning during beating hours, and they work outside to cut the sugarcane. And when they come back to the dormitory, they conduct recreational activities during the evening. Also, before the project, there was a limited access to malaria, to health services for malaria in the plantation. Diagnosis and treatment was present just in centralized clinics, and while the plantations are really big, so those clinics were really far away from where the workers live and work. And also, the services were not present after working hours, so when they were back to their dormitory, there was nobody attending them in case of a fever. Also, their treatment-seeking practice are really limited. One element is due to the linguistic barrier. Some of them come from indigenous community and don't speak Spanish, and the services are provided mostly in Spanish. And as a parenthesis, in Guatemala, the treatment is free and is provided by the Ministry of Health, and they have 3 days of chloroquine plus 14 days of Primaquine, and there is a low confidence from the worker on the quality of free medication, so they prefer to go in informal drug shop and get not optimal doses of chloroquine, that is just one dose, and they can come back to work in the field. So all these elements, the geographical overlap, the seasonality, and the vulnerability and occupational exposure were elements that bring the Ministry of Health and the corporate sector to partner in 2017 and implement surveillance and extend malaria case management in one plantation. The Ministry of Health trained 12 health workers in one of the plantations. Those health workers were decentralized in different clinics on the plantation. The Ministry of Health also distributes diagnosis and treatment tools to each of them and provide a unique code so they can report the cases into the national surveillance system. They also create together a system for reporting the cases at the district level. This system that was created was particularly unique, especially in the way that the services were provided, because we're making the access to healthcare for malaria closer to the worker. For example, in each dorm, after working hour, there was nurses trained and with malaria diagnosis and treatment tools. Also, there were mobile clinics going in the field with the workers when they were cutting the sugar cane, and they were trained and equipped with the malaria diagnosis tools. And finally, the plantation provided also information on malaria symptoms and the risk of malaria in Escuintla and the availability of diagnosis and treatment in the dormitory and in the mobile clinics, and they provided the information also in local languages. So here we can see that in the previous harvest season, before the implementation of the project, we have a high slide positivity rates, probably due to the fact that they were not doing enough testing. The test was present just in one centralized clinic, really far from where the workers were. And after the project, we have the increase in fever tested and cases reported. And this is showing that there was an improvement in surveillance in the plantation. Also, another aspect that make the manner in which the services were provided unique was the follow-up that the nurses were doing at the dormitory level. They were literally going every evening to the dormitory, identify their patient, and providing the treatment every day for all the 14 days of the treatment. And actually, when the project just kicked off in November to February, the proportion of patients that completed the treatment was quite high. 4 months later, both the Ministry of Health and the private corporate sector analyzed the data, and they found out that in one dorm there was a high incidence, a really high incidence respect to the other dorm. So they decided to partner again and implement active case detection and to test all the workers related to that dorm with the limited resources that they had using RDTs and microscopy. And they also provided information to the workers, and they complete the notification form, and they detected 10 additional cases in that dorm. Analyzing again the data from the passive case detection and the active case detection that they implement, the Ministry of Health and the private corporate sector recognize the value of extending point of care in implantation, as well as reporting the cases into the national surveillance system and conducted targeted active surveillance to capture more cases and to target at-risk population. So with the data from the strengthening passive case detection, the Ministry of Health and the sugarcane corporate sector have identified 7 additional sugarcane plantations that are currently joining the project. Actually, this picture is from yesterday, and this is happening as we are talking. And also, they included in the project a strengthening ICBCC strategy with videos that will be dubbed in local languages. And also, they are created a system to improve the follow-up from the nurses or from the health worker to the sugarcane workers, and also the follow-up that the vector control technician will do to the plantation. And all the data will be reported into the national surveillance system at the district level, and eventually the data from the passive case detection will be used to target additional active case detection in case the Ministry of Health and the corporate sector will identify cluster of particularly vulnerable population. So the main conclusion of that is that the partnership between the Ministry of Health and the corporate sugarcane sector is critical in Guatemala to eliminate malaria because of the presence of the plantation in the most endemic region, and also because they move a lot of a big contingent of workers every year in the period of the peak of the malaria season. Also, the improved surveillance is reflected in the increase of fever tested and also in the cases reported by the new testing points that were expanded in the plantation. And the ACBCC strategy is key also for this project to make sure that the workers are increase the awareness on malaria, and they know that there are new testing points for malaria in the plantation. The passive case detection data in this project were used to target additional active case detection to a population at risk. And this is key and can also help to reduce the treatment-seeking delays by bringing the diagnostic point directly where they are needed and where the most at-risk population is. Finally, I want to say that the data are really important and were the key for the success of this project and were used as an advocacy tool to have more sugarcane plantation involved into this project. Finally, I would like to thank you, I acknowledge my colleague at CHAI, the Ministry of Health of Guatemala, and the sugarcane corporate sector of Guatemala. Thank you.
Hi, I'm Alex Macedo. I'm with the malaria branch of the CDC. Thanks for your work, and thanks for working in Latin America as well. My question is related. It does seem to be something related to the workforce. So, you know what I mean? It's a strategy focused on the workforce. I do imagine that those people bring their messages home, and they may have other people sick at home. Is there any integration of how to expand this, or, I mean, do we do anything better for these families that are now know about the disease, and also, like, do we refer them? What kind of support can you bring to the family members of these workers so we can expand this to more community-based level as well? Thank you.
Thank you for your question. Actually, and in parallel to this strategy, the Ministry of Health and also with the participation of the sugarcane plantation are working also in the community because, as you see at the beginning, just 60% of the workers are coming from the north of the country, the majority from surrounding highlands, but also there is 40% of the workers that comes from other localities that are at risk and are in the region of Escuintla. So they are implementing a similar strategy in parallel, both in the plantation and both in the communities. And this strategy also includes ICBCC at school with children and mothers, because they can transmit better the message than to their family.
Graziella, very nice talk. Let me ask, so it's my understanding that these workers are coming from both locally and far afield, and you're doing excellent process and enhancing the service delivery when they get malaria. I had the pleasure of observing a situation in an African country where a sugarcane plantation actually decided to test every worker upon entry into the program, and then gave them all bed nets in order to keep them. So they treated everybody who was positive, then they gave them bed nets, and they essentially shut down transmission in the sugarcane plantation. And that shut down transmission outside into the neighboring areas of the plantation, because there was that had been the source of infections elsewhere. So I'm just curious what you think about sort of a proactive process with the workers as they come on board. Is that an option?
Yes, it could be an option, and this is a starting of an engagement process that took several years, and now there is an interest of implementing a more proactive strategy. But I think this is the beginning, and we'll also have a lot of data from this strategy that can help to improve it in the future.
Please go ahead.
Hi, thanks so much for your work. I'm Gabrielle Hunter from Johns Hopkins Center for Communication Programs. I'm curious about the adherence to the full course of treatment rates that you're seeing among the workers as they're followed by the program.
Adherence to the treatment. Okay, thank you. One thing I want to highlight, that we don't have data on the adherence before implementing the project. Also, before implementing the project, as you have seen, the test rate was really low. So the data that we have regarding treatment adherence are from November through February, so just 2 months. And for just kicking off the project, the adherence was high. And also I want to highlight that the percentage of people that didn't adhere to the treatment were people that leave the work and they come back to their regions in the north of the country.
Great. Well, thank you very much.
Thank you to you.
Okay.